Sorry for that, if you all heard. Coalition Plus was created in 2008 as an international NGO involved in the fight of HIV/AIDS and viral hepatitis. Today, it works with over 100 community-based organizations in 52 countries, and its board of directors promotes an equal voice across Global North and Global South partners. We believe that it is our responsibility as community actors to ensure that the most marginalized are empowered to voice their needs and achieve their demands. The marginalized are those who are underserved by the social and health systems. They suffer discrimination when seeking access to care and have difficulty staying in care when they do access it. Their rights are not respected and their needs have been ignored. We push for communities of people vulnerable to HIV and hepatitis to be systematically involved in the decision-making, development, implementation, and monitoring of health programs that concern them. This is our added value. Several governments in our project's countries stated that communities help generate awareness and played the catalytic role in linkage to care. Today's event takes place as the 2020 targets are being reported, with many regions falling far short of the goals set out in 2016. Moreover, it comes as Unitaid's HCV grant is ending, and with it a major loss in funding to support communities and civil society in the fight against hepatitis C. Without international funding, especially for communities, the HCV momentum might be lost. The risk has become even greater since the emergence of COVID-19, as the pandemic response has absorbed attention and resources. Before I give the floor to my colleagues, I wanted to share some of the main findings and achievements of Coalition Plus's project in the space of collaboration between community and health authorities. Our grant's specific feature is the work done with, for, and by the community in 7 countries: Brazil, Colombia, India, Indonesia, Malaysia, Morocco, and Thailand. During this 6-year grant, community involvement in policy discussion assured that needs and realities of people served are better accounted for. This not only promotes inclusive and accountable governments, it leads also to more impactful and more cost-effective policies. For example, community-based testing enabled us to find more infected patients with lesser tests. All countries that had the audacity of implementing decriminalization policies towards people who use drugs observe a significant positive impact on the HIV epidemic. We are convinced that decriminalization will have a more substantial impact on the hepatitis epidemics. Community-based organizations have the legitimacy to innovate in their approach to tackle HCV. For example, our project contributed to setting up community-led screening campaigns in prison and training to healthcare workers to reduce stigma, demonstrating that the success of a treatment program is not just a quantitative matter of budget and number of nurses and doctors. Through these approaches, communities show their governments some concrete possibilities of success. We have harm reduction, we have prevention tools, good testing technology, and remarkable treatments. We need inclusive policies and financing. We need countries and international institutions to accept that civil society, communities, and government institutions are complementary. Communities have expertise to share, a voice to raise, to sustainably bend the curve of these epidemics. I will give now the floor to my colleague Chase Perfect, who will present all the speakers and moderate today's exciting program of speaking intervention. Thank you all.
Thank you, Jean-Luc. My name is Chase Perfect, and I'm the Access to Medicines Policy Officer on the HIV/HCV Drug Affordability Project. Before launching into the program, a few housekeeping notes. This event will be recorded. Apologies for the late recording start. And due to time constraints, we won't have a question and answer opportunity. However, it is possible to make comments in the chat, and we welcome your engagement. Also, before starting, we would like to highlight that this is the 3rd online event of a series focused on viral hepatitis, with Medicines Patent Pool having hosted an event on Wednesday, as well as yesterday's event organized by the WEF and the Hepatitis Fund. We'd like to thank these organizations for helping us to promote today's event. Without further ado, let's jump in. We have 11 speakers on the program. Some of the interventions will be live, others will be recorded. Our tour will begin in Brazil. And on that note, I pass the screen to Rodrigo Pinheiro of O Fórum das ONGs AIDS do Estado de São Paulo, also known as FOASP.
Olá a todos os parceiros da coalizão. Para nós do FOASP, foi uma grande satisfação atuar nesse projeto da coalizão nas questões das hepatites virais, com esse foco da hepatite C. O FOASP tinha um histórico até o momento dessa parceria com a coalizão de atuar com AIDS. E foi um grande desafio para nós atuar com a questão da hepatite C. No Brasil já existem movimentos, já existiam naquele momento movimentos que atuavam com a hepatite. Mas eram movimentos que se conflitavam, tinha dois movimentos. E para nós também o desafio de conhecer todas as questões que envolviam as hepatites, né? O FOASP é formado por várias organizações não governamentais. Então nós precisamos capacitar as organizações não governamentais também, dentro do estado de São Paulo, para que elas pudessem estar tendo um conhecimento também sobre as hepatites virais e que elas pudessem estar atuando também nas bases sobre as questões políticas, sobre as questões também dos seus usuários que frequentavam as suas organizações não governamentais, sobre a importância da testagem para a hepatite C, principalmente. Esse era o nosso foco, né? A ampliação de testagem e tratamento para pessoas diagnosticadas com hepatite C. Aí fizemos algumas capacitações junto com as organizações não governamentais. Fizemos também levantamentos de projetos de leis que estavam tramitando sobre hepatite dentro do Congresso Nacional, dentro da Assembleia Legislativa do Estado de São Paulo. Conseguimos levantar, tinha um projeto Julho Amarelo, que sensibilizava as ações no mês de julho, com as ações voltadas ao enfrentamento da hepatites virais e principalmente o foco da hepatite C. É um desafio a ampliação de testagem para a hepatite C e continua sendo ainda no Brasil. Ainda mais hoje com a questão do Covid. Mas tinha alguns desafios ainda. A AIDS tinha um processo de fazer distribuição de medicamento muito mais ágil do que a hepatite C. Por quê? A AIDS, o próprio DCCI, o departamento onde está a AIDS, ele fazia essa negociação, compra e essa distribuição. Tinha um sistema de informática onde o usuário pegava um medicamento, o farmacêutico na unidade dispensadora fazia e dava baixa diretamente. O Ministério da Saúde sabia quais as unidades dispensadoras estariam faltando medicamento ou não. A hepatite não tinha esse processo, ele estava num outro componente que era especializado junto com outros medicamentos, combate a câncer, sabe, e vários outros. Um dos nossos propósitos era fazer a mesma estrutura de distribuição dos medicamentos da hepatite, o componente estratégico que nem o da AIDS. Foi uma grande luta ali, uma batalha bem prazerosa de ser enfrentada. Mas a gente conseguiu ter avanços nisso. Nesse processo foi uns 2 anos de negociação junto do Ministério da Saúde, onde a área que estava do serviço especializado, que fazia essa compra e distribuição de medicamentos de hepatite, não queria estar liberando, eles tinham uma dificuldade de estar liberando isso para o sistema estratégico. Mas foi feito, conseguimos fazer uma portaria. Hoje, os medicamentos de hepatite no Brasil, eles estão no componente estratégico, está sendo, junto com os estados e os municípios, formado esse sistema de informática para uma distribuição mais ágil e um controle melhor, né? Agora está nesse processo de acompanhamento desse projeto de implementação. Então, conseguimos esse tipo de avanço. Outro avanço também é de acompanhar as compras dos medicamentos de hepatite C no Brasil. A gente viu que os laboratórios estavam aproveitando uma grande oportunidade que no mundo a questão das hepatites estava muito em voga, de fazer o processo de eliminação da hepatite C, principalmente, até 2030. Vários medicamentos estavam sendo incorporados com menos efeitos colaterais e uma chance de cura muito alta mas esses medicamentos vinham a um preço absurdo, né? Então, uma briga muito gigante aqui no Brasil para poder abaixar o custo desses medicamentos, né? Forçamos muito e a gente implementou uma pauta do licenciamento compulsório. A primeira batalha foi com o sofosbuvir. O Brasil pressionou no governo para fazer o licenciamento compulsório do sofosbuvir, porque o sofosbuvir ele veio para o Brasil $80 mil. Aí começou a baixar o preço, R$80 mil. Aí começou a baixar o preço, mas mesmo assim o preço não era considerado o ideal. O Brasil ficou negociando com o laboratório 1 ano e 2 meses. 1 ano e 2 meses. E nesse processo, as pessoas com novos diagnósticos não estavam recebendo tratamento ali. Questionávamos muito o governo isso ali. Mas nessas negociações conseguiu avançar. Hoje a gente considera que está numa negociação razoável. Hoje não temos problemas com a questão de distribuição de medicamentos para hepatite C. Na questão do projeto de lei, conseguimos a aprovação do júri amarelo, mas vimos que tinha algumas inconsistências nesse projeto. Apresentamos um outro projeto de lei mais completo, né? Hoje esse projeto de lei está numa comissão, eu já tenho um relator, já conversamos com esse relator, ele vai ser aprovado, nós queremos que esse projeto seja aprovado esse ano ainda, que ele fortalece ainda a questão do júri amarelo.
Obrigado, Rodrigo. Thank you, Rodrigo. Voaspi's work has demonstrated, Voaspi's work has demonstrated the impact that can be achieved with resources to sustain strategic advocacy efforts. And the presentation reminds us how important it is to identify and work with key government stakeholders who can champion the cause and move political support forward. Our next intervention takes us halfway around the world to Kuala Lumpur. We are pleased to welcome a presentation by Dr. Radzi Hassan, the head of the Gastroenterology and Hepatology Service at the Malaysian Ministry of Health. Dr. Radzi provides the perspective of program leadership.
Between the comments, I will summarize within 5 minutes the collaborations between the government of Malaysia and also the CSO in our journey towards HCV eliminations in Malaysia. Okay, there are 4 pillars of 4 key players of hepatitis C elimination endeavor in Malaysia. Of course, from the public health system, as well as some of the correctional setting within the public health system, for example, like prisons and also the rehabilitation center. Together with the CSO, we have been working very closely in our effort to get the access of hepatitis C treatment for patients in Malaysia. And I would like to again comment the effort by the CSO has been supporting us all this while, bridging the gap wherever they can in order to help to get the treatment forward. So the best way to illustrate what they have done so far, I think perhaps I can share to you the journey that I've taken so far and how CSO have been helping us all this while. And you all know that Malaysia got our access. We have started our treatment sometime in mid-2018 after we have got our CL sometime in September 2017. And I have to say this again, I mean, the CL is not just the effort by the government of Malaysia, but it's also a joint effort by our CSO who have been advocating for this CL or getting the access of the DAA to our patient in Malaysia. So subsequently, after that, we can bring the generic medicine to Malaysia. So we have started the treatment first in the hospital, and then subsequently we will try to move out from hospital to the community. And we quickly start to realize that we have a problem here. I.e., mainly having a treatment available is one thing, but how to get or link the patients to the treatment or getting or to reaching out to patients or getting them access for the treatment is a major problem. So this is where I think the CSO play their part. This is where they can come in. They are the ones who understand better, especially our clients, because majority of them, like elsewhere in this world, there are all people, a majority of them are the people who use drugs. So they understand their perspective. So they are the ones who are helping us to get our patients, particularly PWID, to come forward and get the treatment. So this strategy of decentralization, which is the key step in our effort to eliminate hepatitis C in Malaysia, will not be a success, will not be what we are seeing right now unless we have the support from the CSO. So we have been extending this effort of decentralization, not just beyond the MOH, Ministry of Health alone, but also we have extending it to the setting outside the MOH, including the prisons, the rehabilitation center, and now we're also extending it to the private setting, including the private GP in the community. And again, CSO has playing a crucial role in linking the treatment access with our healthcare setup in Malaysia. Well, I'll list down here a few of the projects that we have done so far. All these projects are very important because they are meant mainly on how to provide the treatment, getting the access, simplify our treatment policies, simplify our testing strategy. And all these projects will not be feasible, will not be a success because some of them have completed without the help from the CSO. They have equally have important role in all these projects. Okay, FIND project, for example, is mainly mooted by it's mooted by the FIND project or the Head Start project. This is by the CSO also again. So this shows us how important their roles are. And I can summarize that. Apart from that, this is all what have they been helping us all this while. I mean, they have been linking the patients cascade. They have been helping us to expand and accelerate the treatment decentralization, and also they have been great supporter for our research and development. And also, finally, I would like to say that they're not just complementing us, but they are also actively involved in trying to overcome some of the technical glitches or challenges that we have encountered so far along the journey. So finally, I would like to say this again, that it's very important to work together. We can go very far by working and collaborating, not just by us alone working in silo, but it's very, very important that we need to collaborate. And in this case, it's very, very crucial that we work closely. And it's a living proof of success Malaysia has done so far by working together with the CSO. So thank you very much.
Thank you, Dr. Radzi. On so many levels, Malaysia has been a global leader in the HCV response. These first two presentations have shown us the importance of developing strong collaboration with both political and program leaders. From the government viewpoint, we will now pass to an intervention from the community perspective. And for that, we are pleased to be joined by Damayanti Kurasamy of the Malaysian AIDS Council, also known as MAC.
Good morning, good afternoon, and good evening, all from different time zones. I'm Damayanti Kurasamy, Head of Program at Malaysian AIDS Council. Would like to share how essential the role of community and civil society in complementing government's effort towards national hepatitis C response in Malaysia. The Malaysian AIDS Council was initiated and established in 1992 by the Ministry of Health to help fight against the HIV epidemic. In the year 2005, MAC collaborated with MOH in initiating harm reduction program. However, despite of serving the main key populations for the program, MAC only focused on HIV and no other co-infections due to lack of funding. Only with Unitaid funding through Coalition Plus, MEC started to expand on prevention and advocacy work and join forces with MTEP to bridge the gap in treatment access for people living with hepatitis C. Our existing partnership with MOH has helped us to integrate the hepatitis C testing into the national HIV program by setting an indicator for project implementers to refer key population to primary care clinic for HCV testing. Through the Coalition Plus project work plan, we have managed to conduct the first ever multi-stakeholder meeting for HCV in November 2019, where about 70 over stakeholders from different agencies and NGOs attended this meeting. Based from the recommendation of this meeting, Ministry of Health conducted a hepatitis C treatment review workshop in December 2019 to access on the current gap for HIV diagnostic and treatment. Follow-up from this, MOH has implemented decentralization HCV services at primary care centers starting from February 2020. Initially, HCV services were only available and provided at the hospitals. Besides this, the anti-stigma module, which is known as the HOPE module, was developed and many healthcare workers across the country were trained, sensitized to understand our key population better. This really helps to reduce the testing and treatment gap among key populations. We have also conducted many sessions to increase awareness and knowledge on HCV among healthcare workers and civil society organizations. Besides this, reaching out to the key population in the closed settings such as prisons was realized through the MAN project, which is known as a buddy-to-buddy program to help out post-release inmates to seek health services, especially HCV services, after their release from the prison. Many of listed activities above have helped to strengthen community to seek healthy behavior, at the same time complementing our government efforts to eliminate HCV by 2030. We know that Unitaid funding came to an end, but this existing effort needs to be continued in order our KPs have better treatment access so that nobody left behind.
Thank you, Tama. The collaboration to this stage in Malaysia has been really extraordinary, and it will be absolutely essential to the ambitious plans to scale up through decentralization over the next few years. And just to highlight one additional outcome of the collaboration on this project, MAC in fact joined Coalition Plus as a full member, becoming the first member organization based in Asia. From Malaysia, we traveled to Portugal, where Coalition Plus member GAT has been involved in policy dialogues and deeply engaged at the community level. I am pleased to give the virtual floor to Dr. António Salles, the Deputy Secretary of State for Health for the Government of Portugal.
I'm very honored to accept your kind invitation to participate in Coalition Plus webinar dedicated to the essential role of community government relationship in hepatitis C responses. On this regard, Portugal can stand out as a good example on how partnership with community-based organizations has played an essential role in hepatitis C response, but also on HIV/AIDS response. We are celebrating this year the 20th anniversary of drug decriminalization in Portugal and this innovative drug policy adopted by Portugal has resulted in a significant decrease of the burden of HIV and hepatitis C among people who use drugs. In 2019, people who use drugs represented less than 3% of all new HIV diagnoses, which shows that instead of persecuting people who use drugs, it is possible to adopt sound policies and offer them better access to healthcare and effective prevention. The needle and the syringe program, implemented in Portugal 27 years ago, has proven to be an effective harm reduction initiative, providing around 60 million clean needles and syringes to people who inject drugs since October 1993. The opening of drugs consumption rooms, fixed and mobile, and improved access to naloxone and to drug pipes are also features of a successful policy which puts Portugal in a forefront of European and Lusophone countries with regards to drug policies. Portugal is deeply committed to achieving that 2030 WHO targets of 90% reduction in new hepatitis C infections and a 65% reduction in mortality. Portugal created in 2016 a priority health program for viral hepatitis in order to prioritize interventions on this specific area. Until very recently, the HIV/AIDS and the viral hepatitis programs shared the same director. However, such overwhelming responsibilities will now have two separate directors who can more easily devote their time to their respective areas. In 2018, an innovative strategy for micro-elimination of hepatitis C was launched in prisons with a remarkable success rate of 100% of sustainable virologic response on this vulnerable patients population. Portugal started to treat hepatitis C with new medicines back in 2014, and with this new model of care for inmate patients, we plan to diagnose and treat everyone who lives with chronic hepatitis C. Much was already been done, but the challenge is still huge. Much has already been done, but the challenge is still huge. Achieving the WHO targets by 2030 will not be possible without a strategic partnership with community-based organizations. Coalition Plus is the perfect example of how strong civil societies are pivotal to build a world without AIDS and viral hepatitis. Present in 40 countries and with 100 partners, Coalition Plus has conducted a valuable and essential work in advocating for people who live with HIV and or viral hepatitis and key populations to be systematically involved in this design, implementation, and the evaluation of the healthcare programs that directly affect them. Coalition Plus has witnessed firsthand the importance of the complementary relationship between community and government. Communities need policy and financial support from governments to maximize the impact of their mobilization and to expand their community-based care models and interventions to the national level. In turn, governments need community mobilization on the ground, community support in training healthcare workers, and community perspective on policy decisions to design efficient programs and decentralized treatment access. This is key to achieve success. Ladies and gentlemen, now that the Portuguese presidency of the Council of the European Union is coming to an end, I would like to highlight Portugal's deep commitment in promoting public health, human rights, and universal health coverage. This commitment is even greater during the challenging times of a global pandemic. The pandemic was made very clear the need to rapidly respond to public health threats caused by infectious disease. In order to do that, the EU needs to give all the necessary priority to strengthen ECDC and to implement the new EU for Health 2021-2027, the EU ambitious response to COVID-19. Communities and governments will necessarily have to work closer in the near future if we want to recover from this pandemic stronger than before. And bearing in mind that everyone must be involved in order to leave no one behind. Thank you.
Thank you, Dr. Salles. Muito obrigado. As Dr. Salles' presentation has demonstrated, Portugal's leadership on drug policy has had a tremendous impact domestically. Taken together, the community government collaboration in Portugal represents an important example for advocates advancing public health approaches to drug policy. Work on harm reduction has been at the heart of HCV policy, and its impact reminds us of the power that government policies have if they employ the full range of tools available. Communities and civil society have been crucial to the push to employ these tools. For some perspective on the history of this effort and perspective on the evolution of treatment tools, we turn to Gitin Kwarakpam of Treat Asia.
Hello, friends. The work that we are doing for access to hepatitis C treatment has been ongoing for more than a decade now. I'm sure you all would recall back in 2012, end or beginning of 2013, when our colleagues from MSF wrote to WHO to include pegylated interferon as a part of the essential medicines list. A lot of people, including special envoys, UN special rapporteur, wrote to support that, besides many civil society organizations who were fighting for pegylated interferon at that point of time. That was almost a decade ago. On the other hand, we were talking about dropping of price of pegylated interferon. We didn't have a choice at that time, if you recall. And we were talking about $40 a vial of peg interferon. And that was a price that we took as a benchmark from the Egyptian program, which were getting pegylated interferon at that price. We were getting it at hundreds of dollars. And in 2014, in fact, we succeeded in getting that in 57 low and middle income countries or low income countries. But whether or not any government capitalized on that $40 a vial offer out of those 57 countries is a different story. But the point that I'm trying to make here is that our struggle for hepatitis C treatment access has gone a long way. It has come a long way for all of us. Then slowly, with the emergence of DAAs, we started again the same work around inclusive, because the essential medicine list and the medicine being a part of that had a very important role, and we continued including for daclatasvir in 2015. So that process has been ongoing for many of us. In the beginning, when we started getting Indian generics, you would also recall that the civil society people across petitioned the Drug Controller General of India to waive the phase 3 clinical trials so that we get this DAAs as fast as possible. This went on for sofosbuvir, this went on for daclatasvir, this was there also for sofosbuvir and velpatasvir. And I believe that we did also for sofosbuvir and velpatasvir. Subsequently, or consequently, the DCGI, the Drug Controller General in India, waived the phase 3 trials, and that's how we got a lot of these medications, DAAs, across the world so fast and perhaps now at a price that we perhaps would not have imagined 10 years ago. The WHO guidelines also similarly came. So with the availability of medications, the ongoing civil society movement started many things. 2014, the first WHO guidelines, 2016, the global health sector strategy on viral hepatitis. And then, we had the 2018 WHO guidance for hepatitis C, where we say treat all. So we have come a very long way, even for the movement as such, for access to movement, access to treatment, but not only that, but also for the guidance from the normative guidance from WHO to help our countries decide on which way we should be proceeding for diagnosing and providing treatment to the people who needs it. Now, many countries in our region have started working on it, have started implementing diagnosis and treatment national programs, and came along with that the support from Unitaid. And the support from Unitaid perhaps is the one and only now that has supported civil society in a way that could actually allow us to do the kind of work that we want to do. The support was not extensive. The support was not that widespread. It was to a limited number of organizations who in turn could reach out to a very few of us again. But the work and the impact that it has created has been immense. The national programs currently in Asia, for example, in India, in Malaysia, in Thailand, in Indonesia, Myanmar, you name many of these countries, there are a lot of civil society organizations who are now working behind this as watchdogs, working with the government to support the diagnosis, working with the government to ensure that people who need this treatment actually receive the treatment. And even during the COVID-19 times, there are a number of organizations who have been able to provide services to those people because Unitaid allowed it to happen. Unitaid supported this infrastructure, the manpower, the support of these frontline workers to be able to run, to make sure, even during the hardest of this kind of pandemic, we make sure that the people who need hepatitis C diagnosis and treatment are able to receive it. The work will go on. It's unfortunate that Unitaid is finishing or completing its support to civil society organizations, but our work hasn't finished. The civil society movement also has flexibilities, for example, in Malaysia that you have learned. And that was the first flexibility that the national government exercised in terms of accessing hepatitis C treatment. Our work will continue. We will do it. We still have to fight this. It is a decade old, or more than a decade now. Many of us have been a part of it. Some of us joined in the middle. Many will continue to take this forward with or without us. The civil society groups across continues to take the message for hepatitis C. And I'm very thankful to each and every one of you watching this to be able to be a part with all of you in this movement. We have not done enough. The prices have dropped across from $40 of vial of pegylated interferon to now $40 a treatment course for a DAA. But it is not enough. We are not seeing the price and the political willingness going together. We don't see rapid scale up where the prices have dropped down to a considerable extent. So we need to continue to do our fight, and we will continue to do our fight. Thank you so much, Unitaid, for all the support that you have provided so far. We will still continue to need the support that you could provide in the future. In terms of technical or other support, we as civil society groups across the world will continue to work on hepatitis C. Thank you all very much.
Dear colleagues, dear.
A huge thank you to Gitin, who has been such a powerful voice at the regional and international level. His presentation reminds us just how much the challenges have evolved over the past 10 years. And these advances are reflected in the evolution of guidelines. Treat all was a pipe dream 10 years ago, And even with interferon, it was clinically and financially complicated to implement at a public health level for all people living with hepatitis C. Fast forward to today, we now have well-tolerated short treatments that cost less than $100 per cure, where robust generic competition is in place. Unfortunately, not all countries have maximized price reductions, adopted the latest WHO guidelines into national guidelines, or mobilized sufficiently to implement them at scale. And here lies a crucial complementarity between communities and norm-setting bodies. Communities and civil society are crucial to accelerating adoption of international public health guidelines and expanding the capacity of local health systems to implement them. With that, I pass the virtual floor to Dr. Meg Doherty, Director of the Global HIV, Hepatitis, and STI programs at the WHO. Dr. Doherty, you should be able to share your screen and also start your video. Hopefully I figured that out from my side.
Okay, thank you. Let's see if great. I'm on video. And can you see my screen?
Yes.
And full screen now or partial screen? Perfect. Well, thank you very much. It's really been an honor, and I really appreciate and thank Coalition Plus and all of the partners together here for the invitation to have WHO on the panel. And certainly, it's really so wonderful to hear all the experiences that are coming in from both civil society, from countries, and of course, you know, I'm learning more and more about what's been going on in viral hepatitis, because many of you may or may not know me very well, but I have been working in WHO primarily on HIV, and it's so good to see now how hepatitis, HIV are, you know, some of the great lessons learned from HIV have been taken to hepatitis, but then you've done even more because there's such a higher potentiality for actual elimination of especially hepatitis C, but also hepatitis B. So our first message to you is that we know that communities are the center, and that you've made enormous contributions during this time, and is essentially making that link and helping WHO with translating our recommendations and our guidance. And we've seen that you've been advocating for the affordable drugs and diagnostics, advocating for equitable hepatitis services, and especially what we heard today for the most marginalized communities, whether in prisons, whether under duress, whether key populations. So we really appreciate that. Reducing stigma and discrimination and contributing to our new advice, because as we make new evidence, new advice, we need to have a constant process of getting feedback on feasibility, acceptability, and new evidence that could be developed as well in collaboration with civil society. And certainly the COVID-19 pandemic has highlighted how important service delivery and working with communities have been in keeping the work person-centered. Some of you may know on our next message here that we've done well in terms of progress, but we do have gaps, which will help focus us on our next priorities. And the World Health Assembly has been going on this week. Last week, we put out a new report on the progress on our global health sector strategies. And I should say that we have just received yesterday the endorsement and approval of the WHO to move forward developing new strategies for 2022 to 2030. But that's what we're looking at now. What are the gaps affecting mortality, and how can we rapidly scale up to reduce new infections? And you'll probably know there's good news and bad news. The good news is we have 9.4 million people receiving hepatitis C treatment, up 9-fold. And we still have 1.1 million deaths, but there is variability across various regions of the world, with some regions not having yet scaled up adequate testing or treatment, whereas we've seen Eastern Mediterranean region and some of the Southeast Asians, which we heard today, in Western Pacific, also strongly addressing their epidemics of hepatitis C. Similarly, for hepatitis B, we have a lot more we can do in terms of birth dose vaccination and treatment for those who are chronically infected. This report also outlines what areas can be strengthened. And I think many of these areas, if you take a look at the report, are focused on the interrelationship between community and guidance in ministries of health, and using that people-centered platforms, improving access, innovating, stressing the social and structural determinants, and integrating sexual and reproductive health and rights into the response. Lastly, I'd like to say that the community groups have also been very important as we try to move towards 2030. So our next message is, how do we take these strategies and leapfrog and do as much as possible on reducing the stigma and discrimination, advocating for all populations and the countries that are falling behind, perhaps some middle income countries that may not be able to get the price negotiations, and engaging now in a process that we're starting to move forward on validation of elimination of viral hepatitis. This week, next week, we'll be sharing guidance around how we can do that elimination, but we'll need support and help in the communities and in ministries to be able to address this. Creating demands and closing those treatment and testing gaps, looking to new recommendations like hepatitis C self-testing to see how we can bring that forward. And just to note, I just mentioned this earlier, we've been approved to move forward. And I think I'm going to end on a few points around our new strategies where you can really get involved. We're going to have a shared vision and goals to reach ending hepatitis as a major public health threat by 2030. We're looking across 3 diseases on what are those efficiencies, but we really want to leverage primary healthcare, universal health coverage, and integrate some of these responses for greater quality. And what you can do right now, and hopefully you can have these slides, is you can get on and take a survey where you're going to help us identify for hepatitis, HIV, and STIs, what would you like to see in this strategy? How can we do it better in the years to come? And we have a tight timeline where we're needing to represent all of this back in September of 2021 to then go to the next World Health Assembly in 2022. So we hope you can get involved. And I just have to have a shout out for World Hepatitis Day because we believe hepatitis can't wait. So thank you very much, Chase, and to everybody else. We really appreciate that WHO can be part of this. So I'll stop sharing there and pass back to you, Chase.
Thank you. Thank you, Dr. Doherty. And we are excited to see the newest guidelines, and we're ready to support their successful adoption at the country level. And we'd also like to thank the WHO for their consistent engagement of communities and civil society over the past 5 years. So whether it's medicines or guidelines, the existence of these policy tools does not guarantee their fast adoption or successful scale up. We know that advocates are needed to push their governments to adopt the guidelines and allocate the necessary budget to implement them. This includes procurement of health technologies and training of healthcare workers. But to really scale impact, these budgets must also include support for community and civil society partners. As we launch into a crucial decade, the Coalition Plus project is wrapping up. And reflecting on the sustainability of Project Impact, we spent time internally discussing the best way to share lessons learned and the tools that we've developed. We realized that it was important to communicate to a broader audience just what community-led work means and what impact it is having and who it is serving. We also recognized that it was important to share tools and experiences to make it easier for communities themselves to mobilize for impact in the future. For more on the digital project that grew from our discussion on these points, I will pass to my colleagues, Hélène Boscardin-Suandi and Valentina Lombardo.
Hi, everyone. I will share my screen. As Chase has highlighted, the Coalition Plus project is coming to a close at the end of May 2021 after 6 years of activities in 7 countries with up to 17 partner community organizations. Some of the projects are now members of Coalition Plus. This project has become a symbol of extensive community expertise on HCV at local, national, and international levels. It has shown how the community approach has been successful in improving outcomes in HCV elimination, complementing the government's work. Through this project, our community partners have played an important role in the effort to accelerate or expand national policies that scale up access to hepatitis services. The project directly engaged at-risk population to expand awareness of HCV risk and promote access to services through various forms of outreach and support. Partners also provided input in policy processes and advocated toward facilitating expansion of people-centered HCV services, with a particular focus on highlighting the needs of marginalized populations. To achieve these results, partners implemented activities such as HCV literacy workshops for key populations, education trainings for community peers and healthcare workers, social media campaigns. Partners also organized multi-stakeholder meetings, demonstrations, submitted petition letters, and designed training modules to reduce stigma and discrimination, among others. As the project nears its end, it seemed essential to Coalition Plus to make sure that all this expertise could be promoted and conserved in order to present all the successful work done by our partners. In developing an archive, we aim to inspire other organizations to pursue similar prevention, care, and advocacy actions. Therefore, we are pleased to present you with our website, Destination Elimination. Coalition Plus has decided to share all the resources produced by our community partners during the 6 years of the project. In this website, which showcases the photo exhibition that my colleague Valentina will present in a minute. During this project, more than 300 resources have been produced, and we have gathered many of them in the resources center of the website. The website is presented in both French and English, and languages covered by the resources also include Spanish, Portuguese, Bahasa Indonesia, Malay, and Thai. Important resources available also include Mind the Gap, our 2018 report on HCV service accessibility, our December 2020 activist meeting report, which highlighted how the involvement of communities and civil society allows an adaptation of national health responses to the real needs of the people concerned. And the document Mobilizing Communities for HCV Elimination, a guide of best practices aimed at scaling up HCV screening, diagnosis, and access to treatment, an implementing model of care for people living with HCV as developed in our project. With international funding for work on HCV diminishing, particularly in low and middle income countries, it is all the more essential that civil society capitalizes efficiently on lessons learned if they are going to maximize impact. By reducing the learning curve and the operating cost of generating quality content for campaigns, this website and its resource center aim to catalyze the mobilization of community actors seeking to build on the momentum of the HCV elimination efforts. We hope that this website can help inspire other community organizations to start awareness and advocacy campaigns to make hepatitis C a priority for their countries. I will now pass the mic to Valentina, my colleague.
Thank you, Hélène. As Hélène has mentioned, the website hosts a virtual photo exhibition, Destination Elimination, which is conceived and put together with our local partners. It is a journey around 3 continents in 61 photos taken by 6 photographers in Brazil, in Colombia, India, Delhi and Manipur, Malaysia and Morocco. Our guides in this journey are women and men who show their faces and tell their stories in the first person. Despite the diversity of settings, all of them have been confronted with hepatitis C and at a certain point have crossed paths with passionate community activists. So these pictures account for their personal and political experience. They make visible the driving forces behind community mobilization. You will see community actors reaching out to the most vulnerable to HCV at their homes, workplaces, and gathering spots, providing screening and treatment in manners and settings that make the client feel welcome, conducting awareness-raising activities and support groups, and advocating towards decision makers to change public policy on hepatitis C. Destination Elimination is also a photo book. You see the cover. We do hope that you will enjoy this journey. For us at Coalition Plus, it was a pleasure and an honor to be part of it. Thank you.
Thank you, Hélène and Valentina. The Resource Center gives some insight into the scale and scope of work carried out during our project. It also demonstrates that local leadership and local expertise is crucial to the impact of community mobilization. In many settings, the obstacle to realizing such impact is funding, and hepatitis C space concerns over future funding is the elephant in the room. We hope that the presentations today have shown the impact and need for sustained funding of community actors and community systems. 5 years ago, Unitaid stepped up with a crucial investment in a hepatitis portfolio that included several projects, including our own. This funding has been a crucial catalyst for efforts to scale access to hepatitis C services. For more perspective on these investments, we pass to a recorded intervention by Dr. Philippe Duneton, Unitaid's Executive Director, to be followed by live remarks from Roman Théoler, Unitaid Program Officer.
Dear colleagues, dear partners, dear friends, I'm very glad to be with you this afternoon in a meeting organized by Coalition Plus on the fight against HCV. Yes, we believe of the elimination of HCV by 10 years. It's a little time, so we need to be very proactive. Unitaid is proud to have supported simplification of testing, access to treatment, demonstrate the feasibility of program in LMICs, but also the role with Coalition Plus and other NGOs of the advocacy work, demand creation at country level. This is key. In fact, it's even more important now with the pandemic. The pandemic will affect access to care, priority settings, and funding at country level. So we believe strongly that the work should continue in that purpose. Unitaid will also continue to support the fight against HCV, focusing on high-risk groups, IVDUs in particular, and maybe also with harm reduction. Thank you for your work. Thank you for your attention, and we will see you soon. Thank you.
I would now like to pass to Roman Théoler for her remarks.
Thank you, Chase. Hello, everyone. I'll complement the video that you've just
You're mute, Roman.
Can you hear me now?
Try.
Yes.
Try again. Maybe unmute. Maybe we were muted on our side. Okay. If you unmute, you'll be fine.
Yes, I think you.
Perfect. Okay. It was our end.
Yeah, no worries. So I'll complement the video from Philippe Duneton, our Executive Director at Unitaid, with a personal note. So I'm the one speaking today, but actually I'm speaking on behalf of the whole project team that I've been working with Coalition Plus on this grant. So my name is Roman. I've been working with the Coalition Plus project for the past 6 years. And I was there at the very beginning when this initiative was conceived together. So at that time, it was really new for Unitaid to have a grant entirely dedicated to advocacy and civil society. And we've learned a lot. We've seen firsthand that communities are very, very efficient when well-equipped and empowered. And we've also seen them as pushing for equity and equitable access, and that's extremely important. We've seen them, being at the table with national committees, pushing for equity and equitable access, but also on the ground, working with marginalized population. So looking backwards, it's really impressive what the work has been done. I mean, with this project, and moving forward, it's really important that civil society and community are part. I mean, the role is key for the elimination of hepatitis C by 2030. So I wanted to thank a lot Coalition Plus and their partners in the countries for all their efforts in making that project successful. Thank you.
Thank you, Dr. Duneton and Ms. Deoler. Just to note the request for the survey link in the chat, if possible, to share the WHO survey link, that would be great. If not, we'll make sure to follow up. And thank you to Unitaid for the support of the project and their leadership in hepatitis C. I know we're passing just over the hour, so I'll pass to Estelle Tifione-Diawara for closing remarks. And
hello, I'm sorry, I can't put my video on, but I will conclude. I'm Estelle Tifione. I'm the Director for Knowledge Management at Coalition Plus, and I had the great pleasure to overview the great team, the HCV team involved in Coalition Plus in this program. It is today my honor to thank all speakers for their time and intervention today. Their presentations showed us how impactful the collaborative work between governments and community-based and community-led organizations can be when dealing with health, stigma, and criminalization of vulnerable populations. I would like to conclude by saying that if there are two questions to be addressed by all health stakeholders when one is about to work on a health policy, there should be: what do patients and communities need to enter the health needs? And who is the best position to provide those answers? The situation we are going through with COVID-19 leads us to think more than ever about a global approach to the health needs of the most vulnerable and marginalized people. But we'll only be really able to do this collectively when the authorities of our countries and international institutions recognize that our place, that of civil society and local communities, is complementary to that of the governments. We, civil society and communities, cannot just be called upon to implement health programs decided on without prior consultation with the people concerned by those interventions. We are not just health providers. If the international community wants to really leave no one behind in terms of access to care, it is necessary to make use of all expertise and voices, including community expertise. I thank you very much for your time, presentation. I thank the speakers, and this is over. I'm trying to put my video, but I can't, so bye.
thank you all.